Okay, let's go ahead and get started. Excuse me. Welcome to today's webinar, Brachial Plexus and Peripheral Nerve Injuries, Understanding Presentation, Workup, and How to Best Support Injured Employees. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts, in collaboration with Dr. Rohit Garg of Mass General Brigham. We're excited that you've joined us for this presentation. My name is 𝐏𝐿𝐸𝐿𝐿, and I'm the moderator for this webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link where you can access this replay on demand, along with a link to a short survey. Again, we're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'll pass it to our host, Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, MLCC, and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Cindy, over to you. Don't forget to come off mute.
I won't. Thank you all for joining us today. Before I hand this over to Dr. Garg, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series designed to educate claims professionals, HR resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready. For this session, the 4th this year, Brachial Plexus and Peripheral Nerve Injuries, Understanding Presentation, Workup, and How to Best Support Injured Employees, we're pleased to have Dr. Rohit Garg of Mass General Brigham share information about the group of nerves that supply the arms and hands, the brachial plexus, and the peripheral nerves. Timely management can be critical for these devastating and life-altering injuries. Participants will gain insight into injury presentation, diagnostics, and how to best support injured workers in their rehabilitation and recovery. I've been very excited for this because I've been doing rehabilitation nursing for too many years to count or to state here. And this is obviously a very complex injury. And when we get patients, it's always a struggle to get them really good care. So I'm very excited that Dr. Garg is presenting on this. Dr. Garg is a fellowship-trained hand and upper extremity surgeon with additional expertise in complex reconstruction of the upper extremity and microsurgery. He is dedicated to providing exceptional patient care. Dr. Garg started his medical career by obtaining the 3rd highest score in the medical entrance test among the entire nation of India. He subsequently enrolled in All India Institute of Medical Sciences, a premier institute declared an institute of national importance by the government of India. He completed orthopedic surgery residency training at the University of Illinois, Chicago, hand and upper extremity fellowship at Mass General Hospital. Dr. Garg then embarked on additional learning fellowships overseas. In Canada, he worked with Dr. 𝐏𝐿𝐸𝐿𝐸 to enhance his experience in total elbow replacement, elbow contracture release, and elbow trauma. He then went to 𝐁𝐫𝐚𝐿𝐸 Hospital in, Coimbatore, India, where he obtained further valuable experience in microsurgery, adult and pediatric brachial plexus surgeries, complex reconstruction of the upper extremity, nerve injuries and reconstruction, pediatric hand and free tissue transfers. Following that, Dr. Garg worked with Dr. 𝐁𝐫𝐚𝐥 in Thailand, where he gained further expertise in adults and pediatric brachial plexus injuries, with a special focus on shoulder reconstruction and intercostal nerve transfers. Dr. Garg has published numerous peer-reviewed research studies with great impact in the field of upper extremity and brachial plexus injuries. He has presented his work at various national and international meetings and has authored several book chapters. He is an active member of the American Academy of Orthopedic Surgeons and the American Society for Surgery of the Hand. Dr. Garg's clinical interest includes hand, elbow, and upper extremity fractures, post-traumatic deformity and dysfunction, ligament and tendon injuries, nerve injuries and reconstruction, brachial plexus injuries, complex reconstructive surgery of the upper extremity, and the pediatric hand. Thank you so much for joining us today, Dr. Garg.
Thank you, Cindy. Thank you for the introduction. The institution in India is Ganga Hospital, and Ganga and the one institution in Thailand with 𝐏𝐿𝐴𝐿𝐴𝐿, those are one of the two busiest brachial plexus centers in the world. So it was a great opportunity for me to actually visit those places and see more volume of these complex injuries.
And thank you for stating how to say them, because they're quite a mouthful. Thank you.
Yeah, absolutely. So thank you everyone for joining in. My task today was to talk about brachial plexus injuries. So this presentation we're going to divide into a few sections. First, we'll be really understanding the anatomy of the brachial plexus and really understanding what brachial plexus is, because the term itself can be very confusing. And I think this is something that should be understood better. And then really understanding how do these patients present and how do we manage these presentations. So the first thing I'm going to talk about is what is brachial plexus. So simply put, brachial plexus is a collection of nerves that control your entire upper extremity. It's as simple as that. It's just a bunch of nerves that make your arm move and supply sensation to the hand and the entire arm. So we're going to go into more detail on the brachial plexus. So this is taken from Ackland Atlas, this video. So if you look up here, this is the skeleton that you have, and this is the superior thoracic aperture. This is the area from where all the major vessels from your heart go into your arm through this area right under your collarbone. And then you see the vertebra in the back. And from here, the nerves come from the spinal cord, and they also follow the same aperture under your collarbone and go into the arm. So if you look at this, if you remove the collarbone, you see this area from which all the major vessels and the nerves basically go into your arm. So again, the vessels come from the chest, and the nerves come from your spinal cord, which is inside this vertebra. So that's the basic structure on how the brachial plexus is formed and how these nerves control your entire upper extremity. Now, if you look at this schematic here, this is taken from Mayo Clinic, medical library. So if you look at the vertebra here, these are the vertebra that we saw in the previous anatomical dissection. Now, this is the foramen that we saw up there. And this is how from the spinal cord, if you see my cursor up here, you see how from the spinal cord, the nerves are coming out of this foramen right there. And these nerves coming out directly from the spinal cord combine and form a bunch of nerves that control your entire upper extremity. Now, if you look closely here, this is your spinal cord. If you see how the nerves come out, the nerves have two parts to them. The one part, the dorsal part, which is the one in the back, and the ventral part, which is the part in the front. The dorsal part is the part that supplies sensation. So all the sensory function happens through that. And the ventral part is the one that controls mobility. So this part of the nerve controls motion or movement of the arm, and the one in the back controls sensation. And these two combine to form a nerve root that comes out of this foramen. So this is a basic structure which will help us understand the brachial plexus injuries. Now, this is how it looks in real life. So again, we go back to the same schematic, and these are the two muscles, the scalene muscles, which form the boundaries for these nerve roots. You can see the first rib is here, the collarbone is here, and you can see the scalene forms the boundaries. And this is where all the nerve roots, the one we saw previously, are coming out from the spinal cord. So this is C5, C6, C7, C8, T1, and here you have your subclavian vessel coming from the chest. So that's the entire way the brachial plexus is formed. And if we look at this in further detail up here, now this is how it goes all the way into the arm and controls the entire arm. So this is your pectoralis minor muscle, which we have just removed to really look at the brachial plexus. Again, these and this is your subclavian vessel. And these roots and subclavian vessel again come in between the scalene muscles. Now these roots combine to form trunks. So C5 and C6 combine to form the upper trunk. The C7 is the middle trunk, and the C8 T1 is the lower trunk. This is all happening above the level of your collarbone. Now, when you go below the level of the collarbone, these trunks divide to form divisions. And then these divisions are lying in relation to your axillary artery. So you can see the subclavian vessel becomes the axillary artery. And now these divisions form cords, which are lying in relation to the axillary artery. So you have the one lateral, medial, and posterior. So those are the three cords which lie in relation to your axillary artery. And from these cords, you have the terminal branches that come out. So this is the musculocutaneous nerve, which comes from the lateral cord. And this is the one that controls your biceps. Now you have the median nerve and the ulnar nerve that come from the medial cord. And these are the nerves that supply the hand, the small muscles in the hand. And then if you remove all of this and look in the back, then you will see the posterior cord once we remove all of this. So as we remove this, you see the posterior cord, and that's where you will see the axillary and the radial nerve coming out. And I'll show you that. Yeah, so now this is the posterior cord, and this is the axillary nerve, which control your deltoid. And this is the radial nerve, which control the triceps and your wrist extension. So this is how you can see how from the spinal cord, the nerve roots combine together, form these nerve roots that come out. They combine to form the trunk. From that, they go underneath the collarbone, go into your axilla, and divide into various branches that control your entire upper extremity. So looking at this in further detail to really understand how these injuries impact function, all the nerve roots that we spoke about. So again, this is your spinal cord, and this is the dorsal part of the spinal cord, the sensory part, and this is the ventral part, which controls activity. Now, the ventral part of the spinal cord, you see the nerve basically goes and supplies the muscle. So that's how this goes and supplies the motor end plate in the muscle, and that's how the muscles move. The sensory part have connections to the skin organs, and that's how you get sensation. This is the connection that you need for the upper extremity to work. Now, when we talk about brachial plexus injury, how can these injuries happen? So usually these injuries are very high energy injuries. And what happens, so I'm going to talk about the avulsion and the rupture first. So what happens in a root avulsion injury, the impact is so much and so traumatic that the entire nerve root is ripped off the spinal cord. So you can see how in a root avulsion, the nerve rootlets basically are ripped off your spinal cord. In a rupture, it's a very similar mechanism of injury. The only difference is that the nerve roots are still attached to the spinal cord, and it's ruptured distal to one. It's come out of between the scalene muscles. And then you have a group of injuries which is in between. These are the stretch injuries, and these can be at different levels of stretch, and that's what determines how the patients will do after these injuries. So this is what we mean by stretch injuries. So when you have a stretch, and we're going to talk about the classification of nerve injuries here when you talk about stretch. This is the outer covering of the nerve. And this in between, the yellow, is what has been shown here as an axon. An axon is a unit of the nerve. This is the unit through which the nerve conducts, as to say, an electrical signal. So the signal that comes from your brain through the spinal cord, it goes through these units called axons, and that's how the signal reaches your distal organs. Now, when you have a stretch, it can be three kinds of stretch. One, in which the axon is intact. So it's just the surrounding that's affected by the stretch, but the axon is completely intact. If you have an injury like this, then obviously that's going to recover the fastest because the unit of the nerve is intact. Sometimes in stretch, the axons internally get disrupted, and that's called axonotomesis. And that's where it's a higher grade of injury, because what happens when part of the axon dies, and then the proximal part forms sproutings, which have to go and connect where the distal axon was. This process is very, very slow. The nerve grows at a rate of 1 millimeter a day. So you can imagine if you have an injury at the level of the brachial plexus and the nerve has to grow all the way to the hand, how long that's going to take. And that's why some of these injuries, again, if it's a neuropraxia and the axon is intact, it's going to recover quicker because the unit is intact. However, if the axons are injured inside, then it's going to take much longer. And the worst form of this is complete transection, which is a rupture, as we saw, in which it's not just the axon, the surrounding is also injured. And then you don't have a tube in which the axon can grow. And these injuries have the worst outcome. So these are the examples on how the brachial plexus injuries happen. So again, usually high energy injuries, motorcycle accident, motor vehicle accident, industrial accidents. And with this high energy impact, you can see if the neck is getting pulled in one direction, the shoulder is getting pulled in the other direction, you can have the nerve roots that can either come off the spinal cord, or you can have ruptures, you can have stretch. So you can have a combination of injuries. And this is usually what we call an upper trunk injury, in which most of the nerve roots in the upper part of the plexus are involved. And then you have this part, which is the lower plexus injury, which is basically a traction that your arm is hanging up and everything gets a traction injury like that. Then you can have the lower nerve roots that can be either pulled off the spinal cord, or you can have the stretch, and that's what causes the lower plexus injury. Now, you can imagine if you have a brachial plexus injury with such a huge amount of trauma and energy, you would expect to see other injuries as well. So additional injuries for brachial plexus, usually you can have a head injury. A lot of these patients will have either a bleed in the head or some sort of head injury, even a concussion, traumatic brain injury. You can have injuries in the spinal cord or the vertebra. You can have spine fractures. It's very common to have rib fractures with these injuries, sometimes a collapsed lung. And it's very common to have fractures of the same arm. You can have fractures of the glenoid, the scapular blade, the humerus. So it's very common to have these injuries. And at the same time, you can also have vascular injuries. You saw how the subclavian vessel is right next to the nerves, and how when you have subclavian vessels injury, that can happen at the same time of a nerve injury. The mechanism of injuries for brachial plexus also involves, other than the ones we spoke about in terms of high energy trauma, you can also have penetrating wounds, such as a knife or a laceration wound. You can have gunshot wounds. And when the entire plexus is involved, you present as a flail limb. So you can imagine when you have injuries like this, what sort of impact they can have on a patient. So again, these are complex, devastating injuries with a huge impact on a patient's life. The life changes after these injuries, and and then it's up to the healthcare providers to support these patients, not in terms of just returning their function, but also psychologically, emotionally. It takes a huge toll on a person. The other thing that we should know about is, you remember how the nerves get connected to the muscles. Now, the muscles have about 18 months, after which the muscle end plates do not survive. So if we cannot get the nerve signal getting to the muscle within the first 18 months, the muscle end plates will not survive, and that muscle is never going to come back. So we have a timeline when we see these injuries, and that's why the time from injury to the time to intervention should be short for these patients to have the best possible outcome. Otherwise, it's possible that the muscle might undergo irreversible damage. And then you have other techniques that we can talk about. So I'm gonna present some case example to really understand how these patients present, how do we need to work them up, and what investigations we need to order, and what treatment options we have, and how these patients generally do. So the first case I'll talk about is a 40-year-old male. His right hand dominant. He was in an ATV rollover accident in May of 2021. He works in construction. He lives alone with his son, and he presented to me in January of 2022. So you can already see this is 7-8 months after the original injury, because he was seen at outside institution and was told, you just gotta wait and see what recovers, and nothing much can be done, and you just gotta wait for recovery. Now, he did get some recovery. He had very good function of his wrist, his forearm, his fingers, but he had no function at all of his shoulder and his elbow. So the other injuries that he had a scapular body fracture, he had a pneumothorax, a concussion, cervical spine fracture, but all these fractures were treated without surgery, and he did fine with those fractures. As I mentioned, he had no strength or motion in his elbow or his shoulder, but he did have strength in his hand, which is a plus for him because it gives us some options to offer him reconstruction. And again, he was seen at outside institution and told to wait, nothing much can be done. Now, this delayed referral that we see for some of these patients is actually something we studied and wrote a paper on. This was published in Journal of Hand Surgery in 2021. And this is actually a problem even in metropolitan Boston. So the study that we did looked at two big tertiary care centers in Boston, and we saw which patients had delayed referral. Where delayed referral means more than 3 months from the time of injury. And we found nearly half of the patients at these big institutions had delayed referral. Now, what was the reason for the delayed referral? Sometimes the providers or the healthcare workers who are seeing these patients, they don't know where to send these patients, whether to send them to a spine surgeon, a shoulder surgeon, a trauma surgeon. They don't know where these patients need to go. Sometimes it's the local hospital just has a delayed referral, just the paperwork, all the processes take time, and sometimes it's the insurance status. These are the factors which we found were significant that influenced the delayed referral in our case series. So that's why I think it's important to have centers of excellence that treat these patients. At MGH and at Brigham, we actually have a combined program now. It's a Mass General Brigham Brachial Plexus program, where we have started seeing patients in collaboration and starting doing surgeries in collaboration. And we're hoping that by establishing centers like this, we can create more awareness so that these patients can have a timely referral. Now, going back to our patient, now his presentation is at 8 months from the time of injury. He cannot move his shoulder or elbow. And now the question is, what are the next steps? So the first step in really figuring out what's going on is a really complete clinical exam. And I'm just going to play this video to show what we assess. So if you look on the right side for this patient, you can see there's muscle atrophy. You can see there is complete hollowness of the infraspinatus and the supraspinatus, and you can see the deltoid muscle is completely atrophied. You can see all the bones up here because the deltoid muscle is atrophied. Now, the other muscles around the scapular blade, those seem to be working. His rhomboid seem to be working as he's able to retract the shoulder blade. And also his serratus anterior seems to be working as his scapular blade is not lifting off and there is no scapular bending. So this is important to figure out in terms of really figuring out what muscles are present, what you can use, and what level of injury does this patient have. So going further down, you can see that his pec major is working, his trapezius is working. Other than that, there is no other muscle working around the shoulder. You can see he has no elbow motion, there is no shoulder motion, and the latissimus in the back is working. You can see that muscle firing up there. So this is basically helps you figure out that this is very likely a post-ganglionic injury. The roots are usually fine in something like this when you have an exam like this. Now, if you look at the triceps is working, but he has no biceps. The hand just falls and he has no power to make his biceps work. So again, it's a detailed exam like this. This is an exam to look at the deltoid, and his deltoid is not working, but he's able to use the triceps to bring his arm back up. So this is basically the exam, and his hand function was pretty good. And this basically helps us figure out. So because his triceps is working, I know his C7 nerve root is fine. It's basically the C5, C6 nerve roots, and very likely a post-ganglionic nerve injury. So that's about exam. Again, very thorough clinical exam to really understand which muscles work where and which muscles are available in case of what you can do for a reconstruction. Now, when you see these patients, there are always a few studies that I like to get. Some of them are x-rays, the x-ray of cervical spine, because you want to rule out any injury to the cervical spine. Most of these patients will be seen in an ER setting, and most of them will end up having either a CT or an x-ray of the cervical spine. You want to get x-rays of the chest, because again, for some of these reconstructive procedures, you might be using nerves that go into the intercostal muscles in the chest, or the phrenic nerve that control the diaphragm. And you want to know if you have a collapsed lung or a pneumothorax, which might make those nerves not usable for any sort of reconstruction. Plus, you want to know if there's any chest trauma or not. And you want to get a shoulder x-ray as well, because very commonly these patients will have some sort of shoulder fracture, and sometimes when they're not able to move the shoulder, you don't know whether it's a fracture or a brachial plexus injury or a rotator cuff injury that might be preventing them from moving their shoulder. Now, if you have to find out what's happening at the level of the nerves, I like getting two studies. Most of the times I get one study now, it's the MRI of the brachial plexus, but you can get either a CT myelogram or an MRI of the brachial plexus. What happens in a CT myelogram is that you inject a dye into your spinal canal, and then you take a CT. And if there is a root avulsion, or if you remember, if there is a root that avulses of the spinal cord, then the spinal fluid escapes and forms what we call a pseudomeningocele, and that gets picked up with the dye. It usually takes about 3 to 4 weeks from the time of injury to allow these pseudomeningoceles to form, and that's why the yield of a CT myelogram is better at 3 to 4 weeks. The same goes for MRI. I feel MRI is a slightly easier test to be done, and with the new sequences and more expertise with radiologists, I think the MRI is becoming more of a tool that we use more commonly in practice to look at the nerve roots. Again, the goal of these studies is really find out what's happening with the nerve roots at the level of the plexus, if they are still intact or if they are ripped off the spinal cord. The final piece in investigation is usually getting some sort of electrodiagnostic evaluation. Now, what this means is both a nerve conduction study and an EMG. What happens in a nerve conduction study is that you put surface electrodes on your arm, and then you conduct electrical signals through the nerves, and you see if the signals are conducting through the nerve or not. And the EMG is you try to figure out, you stick a needle in the muscle and have the patient activate that muscle, and that helps you figure out if the muscle has some sort of nerve supply to it or is it completely denervated. Now, because of the Wallerian degeneration that we saw from the axons, it usually takes about 3 to 4 weeks for the process to finalize, and that's why the optimal time to getting an electrodiagnostic test is also at 4 to 6 weeks. Now, going back to our patient, now if you remember the exam for our patient, and after we did all the investigation, we figured that the area of injury for our patient is this upper trunk, and it's not from the spinal cord, but it's post-ganglionic, which means it's a rupture which is not directly from the spinal cord, but at the level of the nerve roots. So now when we look at what options we have, we know that our patient has a functioning radial nerve. So he has a functioning triceps. He has a functioning median and ulnar nerve. So he has functioning hand muscles. He doesn't have a functioning axillary nerve and a musculocutaneous nerve. So he doesn't have a functioning biceps. He doesn't have a functioning deltoid. So for something like this, the treatment plan selected was nerve transfer, and I'll explain to you why we select nerve transfer in this patient. So the principle of nerve transfer is that it takes an expendable nerve that does some other function. So let's say a nerve that maybe flexes your wrist. That nerve will have multiple fascicles, multiple axons that control and flex your wrist. So you take one of those fascicles or two of those fascicles under microscope, you dissect the nerve, and you take some of those fascicles that control the wrist, and you preserve the rest of the nerve, and you take that expendable part of the nerve and connect it to the nerve that's not working. So what basically that does, again, a distal functioning nerve is transferred to the non-functioning injured nerve, flows to its entry into the muscle. So it really bypasses the area of injury in the brachial plexus, and it really goes distal by doing this transfer. So this is an example of the commonly done nerve transfer. This is the same patient, and we did the nerve transfer for him. So let me orient you. So the head of the patient is to the upper right of the screen. That's where the shoulder is. The hand is to the lower left of the screen. And this is the biceps muscle up here. And this is your nerves going into the biceps muscle. So you can see this nerve is the biceps branch, supplies the biceps muscle. And this nerve is the branch going into the brachialis muscle. And this is the nerve that's not working. That's why the patient has no biceps, no brachialis. So what we do in this scenario, we dissect these nerves, the ulnar nerve here and the median nerve here. We dissect these nerves. Under microscope, we find some fascicles of these nerves that are expendable from both the ulnar and the median. What we do then, we cut the nerve going into the biceps right there, and we connect the nerve from here into this nerve. And this is what it looks like. So you can see this was the nerve that was going into the biceps. So we cut it proximally, so it's still going into the biceps, but we get it a nerve supply from this part of the ulnar nerve by connecting these nerve fascicles into the nerve to the biceps. We do the same thing for the nerve to the brachialis. Now, what that does is this nerve is going to grow into this nerve and start supplying the biceps muscle. And that's how you can get innervation into these muscles. We actually did a study on nerve transfers versus nerve grafting. So you can imagine if you have an injury to the brachial plexus, if it's a post-ganglionic rupture, where you still have the nerve root that's intact in the spinal cord, you can even go back into the brachial plexus, take a nerve graft, like a pseudo nerve graft from your leg, connect that nerve root and connect it all the way to the nerve that supply your arm. Now, that is different than just going distally into the arm and doing a nerve transfer. This was a study we did, a systematic review back in 2011, and this was published in Journal of Bone and Joint Surgery. What we found that for patients with complete traumatic upper plexus injury, the same injury that this patient had, the nerve transfer outcomes were better than nerve grafting outcomes. And that's why for these injuries, we prefer doing nerve transfers rather than going all the way and doing a nerve graft from those areas. The benefits of nerve transfer, again, as you can imagine, the transfer that we did from this nerve to that nerve is very close to where this nerve goes into the muscle. So if you remember the 1 millimeter per day that the nerve has to grow, the distance that it has to grow to start innervating the muscle is much smaller if the transfer is done at the same level where the muscle is being supplied. So it makes a shorter time to reinnervation. And that's very critical in a patient like this who is presenting at 8 months. If you try to do a graft from the neck all the way up to the muscle, the time might pass before the nerve even grows from the neck all the way up into the muscle. The other benefit is that it avoids multiple areas of nerve coaptation. So you have to have only one connection when you do a nerve transfer. And again, there is minimal donor morbidity. Doing these nerve transfer does not really affect the function in the hand. That function stays perfect because the dissection is done under a microscope to really get an expandable nerve fascicle that can be used to supply and do the nerve transfer. So that was one of the nerve transfer we did for this patient. The other thing that we did for this patient is really explore his axillary nerve and the suprascapular nerve. Now you can see when we stimulate this nerve, he started to have some stimulation in his deltoid. And I'm not sure if we'll be able to see this, but his suprascapular nerve and the deltoid nerve, just by freeing the scar around them, were having some stimulus. So we did not do a nerve transfer at the level of the shoulder. Now, I don't have the most up-to-date videos of this patient. So this is the same patient at 3 months post-op. You can see at 3 months, he's already starting to activate his biceps. Now you can see I'm having the gravity help him, but he has control of the biceps muscle already. You can see the flicker in the biceps muscle already at 3 months. That's again because the nerve transfer is done very close to where the muscle is being supplied. The patient is about 10 months from the time of his surgery now. And at present, he can flex his arm and reach his face up to his mouth, and that can reach about 70 degrees of shoulder abduction. So it's a long process, even done so. Even the nerve transfers have a prolonged recovery, and you're looking at about 1 or so years, 1 to 2 years, to really see how much recovery you get. So again, it's a long process, but at right now that 10 months doing pretty good, but we would expect more recovery over the next 8 to 9 months. Now, the other critical part about these nerve transfers is to really understand the therapy aspect of it. Is how do you how do you do therapy? Now, when you have these patients, when you do a nerve transfer, let's say you transfer the nerve that supplies the wrist and that makes your biceps move. And these patients have to learn in their head that, okay, when I move my wrist, it's actually going to move my biceps. So that's how you need to learn the nerve transfer. And that's where the occupational therapy becomes so critical. By really, you have to learn to move something else in your head, and that's actually going to move your biceps. You think about moving your triceps, and that starts moving your shoulders. So when you do these nerve transfer, you really have to think about how to start occupational therapy or physical therapy. The other modalities that are commonly used, and it's very critical for patients to have the cognition. Again, if the patient has a traumatic brain injury, some of this might not be feasible. The other thing is the mirror therapy, where you can have the other side perform some task, and in their head, they think it's the injured extremity that's doing that. And you can have E-stim biofeedback. And some of it is very helpful for pain management, because a lot of the time, patients with brachial plexus injury will have severe amount of pain. Now, whenever you have a nerve injury, a rupture or a stretch, it can become very, very painful. And pain management can be very difficult for some of these patients. And that's why some of these modalities, such as a mirror therapy, E-stim, sometimes can be helpful for managing pain. And the other thing that we do for these patients is we have a pain specialists who are in that program who actually manage pain for these patients. And sometimes it's medication, sometimes it's other modalities, but it's a combination of these things by which we manage these pain symptoms, which can again be a huge problem for some of these patients. Let me close this up. All right, so let's move on to our next patient. This was a patient who had a head-on collision with a bus in 2020. He had multiple rib fractures, pneumothorax, coracoid fractures, scapular body fractures, and initially he presented with a complete upper plexus palsy, which is the same kind of injury that we saw in the previous patient. However, in this patient, he actually recovered his elbow. He did have some burning pain in his upper arm, which I believe was again part of his nerve injury and some sort of recovering nerve. Now, this is the patient at 4 months. You can see he has pretty good function, but on the right side, you can see he cannot get his arm up. Like his arm doesn't go beyond that. So at this point, since it was only 4 months from the time of injury, we wanted to see if he has any injury to the shoulder itself or the rotator cuff. So the next step for us was to get an MRI of his shoulder. Now, when we look at the MRI of his shoulder, you can see the tendons here are actually intact, but the muscle has edema, which means the muscle is not getting the nerve supply that it needs for it to function. So at this point, we thought it's 4 months, there's still a chance for this to recover, so we gave him some more time. Now, we also got an EMG, which again showed that the nerves which are supplied by the suprascapular and the axillary nerve, the rotator cuff, as well as the deltoid, are not working well in this patient. So he continued therapy. Now he's at 8 to 9 months. And this is at 8 to 9 months. It actually seems he regressed a little bit. His motion actually got maybe a little bit worse, maybe stayed the same, but did not improve. So for some patients like this, who have some sort of injury around the shoulder, who have plateaued their recovery, we have found that doing a neurolysis or releasing the scar around the nerves can be helpful to help these patients recover. So we brought this patient to surgery. This was at about 9-10 months. And you can see we dissected down in the quadrangular space, found the axillary nerve, and you can see once the nerve is freed, it has a very strong stimulation of the deltoid muscle. And we did the same thing for the suprascapular nerve. Now, this worked out pretty well for this patient, and he's able to get his arm. As you can see, the right side is the one that's affected. His abduction is full now. His forward flexion, this video is from a few months ago, but he has a full forward flexion as well now. So he has recovered very good function in both his rotator cuff as well as the deltoid. He did have some issue with pain management, and some of this nerve releases did make his pain better, but it did take occupational therapy and some pain, some medications such as gabapentin, Lyrica, which really helped manage his pain. And overall, he's doing much better. But again, this is something that took about 2 years for him to fully recover. This is slightly different example, but this is a principle that we apply very commonly in traumatic injuries as well. This is a patient who presented to us at the age of 29 years. She was born with a brachial plexus injury because of shoulder dystocia, and she had some surgeries at the age of 9 months. Now, she presented with basically very limited function of the left hand, the left shoulder. Now, this is, you'll see one of my colleagues in the blue suit, Dr. Elasani is one of my partners who joined us from Mayo Clinic, and we are having our brachial plexus program together with him. You will see how she has a movement at the distal part, but the shoulder itself has very limited mobility. And what you would see here is passively, we can bring her arm up, but actively, she really doesn't have, if I bring it back here, you can see actively, this is all what she can do in terms of raising her arm up. She doesn't really have that stability or strength in the shoulder to raise her arm up. And her main complaint was her arm is really not that useful because she's not able to reach her mouth, she's not able to reach her head, and she doesn't really have much activity in which she can really raise her arm. So for something like this, again, this was a slightly different case. This was a shoulder dysplasia. You can see the shoulder bone is not well formed. But for something like this, we decided to perform a shoulder fusion. Now, what that does, as you remember on the examination, we know the muscles around the shoulder girdle are working well. So what we did is we fused the glenohumeral joint where the patient did not have much motion, and that allows it to have a stable platform through which the muscles around the shoulder can actually work. So this is before surgery, and here you can see after the shoulder fusion, now the patient can actually raise her arm above and reach her head and reach her mouth. So she's very happy with that. But these are the same principles we can apply for some of these patients with traumatic brachial plexus injuries, where sometimes the shoulder fusion can give them more mobility around the shoulder because of the scapular blade. Okay. And the last case I'll quickly talk about is a complete plexus injury. This is a very, very difficult injury. Again, this is the type in which all the nerve roots are not functioning. This was, again, a motorcycle collision, multiple other injuries, subclavian artery injury, open femur fracture, closed femur fracture, open distal radius fractures. And he basically had a flail right upper extremity. And this is the patient where sometimes you have very difficult time managing pain. He has severe pain distal to the elbow, and no sensation in the upper extremity. Now, this is his MRI, and you can see the pseudomeningoceles forming here, which is an indication that this patient has a root avulsion injury where the nerve roots are ripped off the spinal cord. Now, and you can see in the EMG that we obtained, you can see NR means not recordable, which means all the latencies are not recordable. All the muscles have fibrillation, which means there is no muscle that's working in the entire upper extremity. And again, this is the worst form of the brachial plexus injury. Now, this is his exam pre-op, and you can see he doesn't have much in his arm. This is basically, he can shrug his shoulder, but that's all what he can do is in his entire arm. So something like this, you really have to think about what's available, what's not available. So for someone like this, you have a few extra, so that's the spinal accessory nerve that he can use to shrug his arm, but that's about it. So you really have to think about what you can use to try to get some sort of innervation into the muscle. So if you see these patients within the first 6 to 8 months, you can try doing a nerve graft from the muscle, from the nerve that supplies the trapezius, the spinal accessory nerve. You can try connecting that nerve all the way to the musculocutaneous, or the nerve that supplies your biceps muscle, and hope that that nerve grows in time to get you some function back. And this is what we did for this patient, is we found the spinal accessory and we basically connected it with a nerve graft. The other things you can do for patients like this is sometimes when they're too late or nothing much is coming back, you can take a functioning muscle, that's the free functioning muscle transfer. You can take a functioning muscle from the leg, very likely a gracilis muscle. You can take that muscle with its nerve supply, with its vascular supply, and basically connect that muscle in the arm so that you connect the vascular supply as well as the nerve supply to make that muscle work in the arm to get some of the function back. So those are the few things you can do for these patients. And lastly, you always have to remember, some of these patients might undergo multiple procedures to get some sort of reconstruction. And to be honest, the reconstruction usually works better than an amputation, but sometimes in the back of your mind, you should always think about an amputation as a potential option. Sometimes an amputation can be an option, and this was a recent study published from Mayo Clinic in which they actually looked at some of these patients who received an amputation, and you always have to keep that as part of your armamentarium to offer these patients. So to summarize, again, these are complex, devastating injuries. You need a multidisciplinary approach, and that's one of the reasons we have established the Mass General Brigham Brachial Plexus and Nerve Program, where you have shoulder surgeon, we have plastic surgeons, we have orthopedic surgeons, hand surgeons, we have the occupational and the physical therapist, the neurophysiologist who perform the EMG, we have the pain specialists. You need all input from all these people to manage these patients, because these patients have multiple different problems. The one part we are missing is probably social workers, because again, this can be very tough for them in terms of having a job or having a source of income. One thing I would say, a timely referral is key for these patients. As you saw in all these case examples, you have a finite amount of time for these nerves to actually grow and start supplying the muscle. So timely referral can be very critical to help in some of these reconstructive processes. Again, you have to perform detailed exam investigations. The recovery is often prolonged, so you have to have that kind of support for these patients to undergo that kind of recovery. Most of these patients will need some sort of modifications lifelong. And however, still you can have meaningful recovery in a lot of these patients with various techniques that we have available. So that's all I have for now, and happy to take any questions.
Awesome. Thank you so much, Dr. Garg. I know that our participants have learned a wealth of information. We have quite a few questions, so we're going to dive right in. While you're thinking about questions, or if you're just waiting to hear the answers, I do ask that you scan the QR code here so that you can complete the survey for this session. The first question is, it's a multi-part, so I'll read it in its entirety and then maybe go back one by one. But how frequently do you see, if ever, a patient develop CRPS following brachial plexus injury? And then what typically causes this CRPS to develop in some patients?
Great. So I think that's a very good question. So that goes back to the same point about some of these patients have extreme amounts of pain. So when you talk about CRPS, the complex regional pain syndrome, it's two types, type 1 and type 2, and it's based on if you have a nerve injury or not. So if you have a nerve injury, sometimes a nerve injury can create a cascade of events that can cause symptoms, which we term CRPS, which can be extreme amount of pain, temperature changes, skin color changes, all those things. So just the fact that you have a nerve injury can cause CRPS, and those things are sort of interchangeable. Now, and that's what I would say causes CRPS kind of presentation in these patients. But I think the underlying problem is the actual nerve injury.
Okay. In continuation, if it does cause the CRPS, is that usually acute, subacute, or chronic? What's the best treatment path for those that develop any one of those types of CRPS or RSD? And what is the best type to provide? I guess what's the best care for those and how to treat for that CRPS or RSD?
So for patients who have a lot of pain, you need a multifactorial approach, multidisciplinary approach to these. So some of these changes because of the nerve injury, sometimes you just, when you explore the plexus, sometimes stimulate the plexus, sometimes do certain sort of nerve reconstruction, that itself can be helpful in managing pain. Occupational therapy, again, the mirror therapy that we spoke about, the 𝐸-stim, all those modalities can be helpful in managing pain. The pain specialists do have a role in managing pain, again, using medications such as gabapentin, sometimes even on SSRIs can be helpful in managing some of these symptoms. So again, it takes input not just from the surgeon, it takes an input from the pain specialist, the occupational therapist, the physical therapist, to really help manage this pain, and sometimes even counseling with a psychologist to manage some of these symptoms. So that's why it needs multiple people involved to manage these symptoms.
Thank you. Yeah, that was the person's question, was the type of provider, and it feels like you named them all. Here's another question. For this type of injury, what type of physician would be the best to make the referral to?
So that's a great question. There are multiple kind of doctors who are specializing in brachial plexus surgery. Usually, if you look at North America, usually it's hand surgeons who are treating brachial plexus injuries. But what you will see is that there will be some centers of excellence that are going to come up, and that's where you will see these patients that have to be referred. Now, if you look in the Northeast, I know New York City HSS has a center where they see these patients. Other than that, Mayo Clinic has a center, and now we are starting a center. So I think having that information will be very helpful for providers to do a referral. But I think overall, it's the hand surgeons who primarily are doing brachial plexus surgeries in the United States, but only a few of the hand surgeons will do that. So it's the hand surgeons who have the expertise and specialization in this. Sometimes you will see neurosurgeons who are doing brachial plexus surgeries. And again, the plastic surgeons are the only ones who are doing hand surgery, will be the one doing brachial plexus surgery. So it's mainly hand surgeons, sometimes neurosurgeons who are doing brachial plexus surgeries in the United States. But again, I think in terms of referral, establishing these programs in a regional setting will be very helpful for patient referral.
Okay, thank you. Another question, and please, folks, if you have more questions, use the Q&A feature to submit your questions. This one is, do you find patients who have nerve surgery, do they have significant nerve pain afterwards? And if so, what is done for treatment?
I would say the nerve surgery itself does not cause much nerve pain afterwards. What I would say is, when these patients have brachial plexus injuries, the nerve pain is bad before the nerve surgery. What happens after nerve surgery, some of that nerve pain might be less. The pain that they might experience after sort of a nerve transfer or a nerve grafting is the nerve regeneration. They might feel the tingle go down the nerve or some sort of a shooting pain go down the nerve. That's when the nerve fibers are coming back. A lot of the times, again, when you manage those symptoms, you have to think about sometimes pool therapy, mirror therapy, medications such as gabapentin, SSRI. So you have to think about all those tools again when patients have those symptoms.
Thank you. Another question, how soon after a transfer is the patient able to move their arm? And then additionally, how soon would you start therapy after that?
It depends on the type of transfer. So we're going to let's talk about the most common, the transfer that we do at the level of the elbow. So I would expect the first 4 to 6 weeks, I don't have them do much because the nerve is still trying to regenerate. I basically put them in a sling most of the time just to prevent any stretch on the nerve coaptation site. After 4 to 6 weeks, there is some role of E-stim, but we don't really use much of that in our practice. I would say at about 2 to 3 months, we start real occupational therapy in terms of really trying to start stimulating the function that's going to make the elbow move. And that's when we really start occupational therapy to make that nerve transfer work. Now, occupational therapy for these patients starts even before surgery, because even before I do the nerve transfer, I have the occupational therapist work with these patients to strengthen the muscle group or the nerve group I'm going to take as an expendable donor. So I have them start working on strengthening that part, keeping the joints supple, because if your joints get stiff, then no sort of nerve or muscle recovery is going to give you any meaningful function if your joints are stiff. So the therapy component actually starts even before surgery, but to really make the nerve transfer work, if I understand the question correctly, that's something I started about 6 to 8 weeks.
Okay, thank you. All right, I think we have 2 more questions. If you have one, folks, please submit them. This one is, with a child with a brain injury, would you follow the same plan of care or would you wait? Excuse me, a birth injury, not a brain injury. My apologies.
It's a different set of rules for children. So for children, what we do is we really look at the biceps is the critical part for them. So we look at 3 months, are they able to, so the test is called the cookie test. Can they bring the cookie to their mouth? And we usually follow the biceps along. If by 3 to 6 months they have biceps recovery, then we tend to watch and do reconstructive procedures for the shoulder because their distal function comes back. However, if they don't have any biceps recovery, then sometimes at 6 to 9 months we do an exploration as well as sometimes nerve transfers or nerve grafting in pediatric population as well.
Okay. Our final question, so we can end on time, is, do you see a phantom pain with amputations for this diagnosis?
Yeah, that's always an issue with any sort of amputation. What I would say is if we have any functioning nerve that remaining and we're planning an amputation, we usually do a targeted muscle reinnervation or an RPNI technique. These are the new techniques, the targeted muscle reinnervation or RPNI, in which we take the nerve and basically loop it around through a nerve graft. And these are the techniques we would commonly use if we have any functioning nerve left, to try to decrease the incidence of pain at the amputation site.
Okay. Well, thank you, everyone. We're at the top of the hour for joining our fourth and final session of the 2022 Injury Insight Series. Dr. Garg, if you could move to the next slide, that would be awesome. A playback of this webinar will be available within 48 to 72 hours. And if you've missed any of the sessions of the 2022 series, you can find them at medicalandlifecare.com/injury-insight. Also, please take the time to complete the webinar survey. It'll also be in a post email from Zoom. There's a link there if you didn't have time to do it during our presentation. And then finally, certificates of course completion will be emailed within 5 business days. Please note that the continuing education is for 1 Massachusetts Public Insurance Adjuster credit or 1 Certified Case Manager credit. Again, Dr. Garg, thank you so much for presenting this. This was amazing. And thank you to everyone who registered and attended, and look forward to the 2023 Injury Insight Series, which will be announced in January. Cindy, any final thoughts?
No, just that was absolutely great, Dr. Garg.
Yeah, thank you
still
for
have a
having me.
million.
It was a lot of fun.
I have a million questions still, so I'll be calling you at some point here. But
right,
thank you so much. Thank you.
Yeah,
All
absolutely.
right, thanks everyone. You have a good day.
Thanks.
All right.
Bye-bye.